that there's still people are trying to get in to collaborate, so we might wait a minute more and then we'll start this next data science webinar by Dash. Yes, everybody that's trying to get in is now in, so maybe there will be more people coming, but I think we should start because of the time. It's already 4:02, so we should begin. This webinar this afternoon will be on the data revolution in the intensive care unit. It will be given by Lucas Fleur. I'll introduce him a little bit more later on, but first we would like to give you a short introduction because this webinar is organized by DASH, the Data Science Center in Health of the University Medical Center Groningen. We are a group that is helping people out with getting data science more to a higher level and used more often within the UMCG. We do this by different things, and you can see that here on the slide. We have projects that are ongoing. We have community building, collaborations. We assist in getting funding. We have the machine learning lab where we run machine learning projects together with different departments. We look at needs assessment, so what is needed. We try to do as much on education as possible, so we are involved in educational activities in the university, in the different faculties, but also in the medical faculty and in the UMCG, and also by organizing events like this, where we also try to educate you on a certain topic. The final thing that we do is communication, where we try to communicate about what is done at the UMCG about data science, what kind of projects are going on, and try to make that more publicly available and known. For today's webinar, I would like to ask you to put your microphones on mute. If you want to ask a question, you can do that in two different ways. On the one hand, you can raise your hand. You have a little icon with a doll, a figure that is raising its hands. If you click that, then we'll see that also. And we can give you the microphone, and you can open your microphone and ask your question. You can also type questions in the chat. We will later on try to answer them. Maybe if there are urgent questions, Lucas is also prepared to take them in between. The webinar will be recorded and can be viewed later, so it will be available later through our YouTube channel, where you can find all our webinars and short lectures. All the materials that we create will be on there, and you can still access those and view those later on, or refer other people to them when you think they would be interested in looking at this recording later on. So today we have a guest from Amsterdam, Lucas Fleur. He's a PhD candidate in artificial intelligence in the intensive care unit, and he's a resident at the intensive care medicine at the Amsterdam UMC. And he will give his presentation on the data revolution that's going on in the ICU. And we were just talking before this session started that indeed he already started before COVID, but with COVID it has even become more with the data revolution, and a lot of attention also going to the processing of data in the ICU. So with this, I would like to give the word to Lucas and let him do his presentation. Lucas, go ahead.
Thanks a lot. Thanks for the great introduction, and thanks for the invite to speak for you guys today. So the talk today will be about the data revolution in the intensive care unit, which I think is a bit of an ambitious title, but I think that suits the field really well. So before we get started, I think we were going to try to raise a poll to get a little bit of a sense for who's in the audience today. And I think the first poll could pop up. I think it pops up in your screen. You should be able to see it and be able to answer the poll. So the first question, I think it popped up just now, is how would you describe your background? You can click on the screen, either clinician, data scientist, staff, other, or pre or slash clinical researcher. So I think almost everybody has responded. I think like this. So I think most of the people in the audience would identify themselves as a data scientist, and a lot of people would say other. I think we also have a second poll question, so I'll close this one. And then I think the second poll question should be able to pop up any second. If it works. Otherwise, it'll pop up in a second, and we can get to it then. I'll go on to there it is. So the second question for today is: data science is completely going to change the way we practice medicine. So we have fully agree, probably, maybe, not likely, or definitely not. All right, nice. So I think there's a little bit of debate there still. Most people would say probably, which I think is interesting. All right, so the presentation today, I will definitely not eat up the entire hour, but I'll give my lecture, and then I'm hoping there will be some room for discussion and questions. I think I'm going to be talking about the projects that we've set up throughout the Corona crisis, and that we're hoping to set up after. But I think with these projects, even more questions will come up. So I think it'll be nice to discuss those during after the talk. If you have any questions in between, please feel free to ask your questions. I have some discussion questions also prepared for the end. So if we have time left, we can get to those discussion questions as well. I'd be happy to hear everyone's input on those. And so today I want to talk about COVID Predict, which is one of the projects that we set up in Amsterdam in trying to gather data from different intensive care units throughout the country to assemble all this data and to then hopefully learn from these data. And this idea for this project was very much born at the beginning of the crisis, because the pandemic, we saw it coming, it spread through Europe, and then came to Holland, and we were very much unprepared from a medical point of view in what was going to happen and what sort of patients we're actually going to get in the intensive care unit, what the course of the disease is going to look like, and how to best treat these patients. And so then very much at the beginning of March last year, we thought, what if we can gather this data and hopefully gain more insight that way. So there were two main questions that we had at the beginning of the crisis from a medical point of view, which was the disease course. It was unknown, which led to a lot of uncertainty, both for the medical professionals, but also for the families, because we didn't know what to tell the families about what was going to happen to their loved ones. And secondly, I think was treatment, which was also unknown, which led to a lot of treatment variation in different centers. So a lot of hospitals, there were a lot of theories about the physiology behind COVID, and everybody treated these patients to the best of their knowledge, but that there was no uniform sort of set of treatment guidelines, which would have probably led to a lot of treatment variation across the country. I think this treatment variation, the benefit of that is that we use models to pick up on this treatment variation and hopefully learn from the treatment variation, and also learn from different outcomes in the light of different treatments. So there was this loop, there was an unknown disease, treatment variability, which led to differences in variability in ICU data. And we were wondering, can we get a hold of this data to then hopefully unravel this new disease in the intensive care unit? Then why did we specifically wanted to focus on multi-center data? Because we could have kept it to single-center data, but I think some were mentioned already that this treatment variation was there across centers. We also saw from some preliminary studies from other countries that there was a lot of patient variation between centers. Some were from different backgrounds or different cities with different demographics. So we saw patient variation there. Then we know there's different levels of care. Some hospitals provide, for example, extracorporeal membrane oxygenation, some treatments that they wouldn't provide in other centers. So that would have led to differences. And we know there were a lot of patient transfers, especially in the beginning of the crisis, when the south of the country was burdened with a lot of patients, whereas the north was still waiting for the wave to hit them. So there was a lot of spread of these patients. And so our main vision or our main goal for this project was, can we learn from data, and can we learn from critically ill COVID-19 patient data from multiple centers? And so we coined this project the COVID Predict project, which was very much a collaboration between Dutch hospitals and the Dutch Association for Intensive Care Medicine. And I would like to go over the two main aspects of this project. First is a more global project overview, and second is more content-wise. What were the sort of some of the major challenges that we came across in trying to assemble all this data? So first, I'd like to show an overview picture of what this project looked like. So on the left side, you see the hospitals in the Netherlands. So we have academic hospitals, teaching hospitals, general hospitals, and we have three main intensive care systems, electronic healthcare systems that are used in the intensive care unit, which are Medivision, HICS, and Epic. There are some hospitals, but that's about a handful that use other systems, but we aim to focus on these three main hospital systems. So we try to gather data from these intensive care units, from these systems, and aggregate them into a centralized data warehouse. And from that data warehouse, we'd clean these data so that they would be useful for doctors, researchers, data scientists for research. And on the right side of the screen, you can see that we're particularly interested in machine learning questions, but I think these data are suited for different questions, and you don't have to necessarily use machine learning for the sake of it. So there's also a lot of more descriptive approaches or classical statistical approaches that you could take to answer clinical questions that we had at the time, and we still have. We very much set up the project to be a collaboration between all these hospitals, so that all the hospitals that participate in this project would also have access to the data, and so that everybody from these hospitals would also be able to do research with the data that we collectively gathered. And so then the question we often get, and so what sort of data is then in this data warehouse? What did you aim to collect from these patients? So here, this is more of a schematic overview of what sort of data we were interested in. Of course, you're interested in the demographic data. I'll come to this later, but we received pseudonymized data, so we will not have information on address, names, or where they're from, or any VSN numbers, so social security numbers. But we'll have data on the gender, on age. That is all collected in this demographic data. We have comorbidity data. Comorbidity is not routinely collected in health record systems, so we use the NICE data that is collected on a national level in intensive care units. It's an established registry program that, and we use their data to get comorbidity data. And then the intensive care unit is a naturally rich environment for data from all the machines that are in the intensive care unit, that the monitors that shows the vital signs. We have a lot of device data, so from mechanical ventilators, renal replacement devices that we included in there. We have all the medication data. All the medication data is usually logged. So we have that. We have the laboratory results. We have clinical observations that are inserted into the system by mostly nurses. And we have outcome data, which is mostly length of stay, mortality. For most of the hospitals, we would also have hospital mortality, or even mortality after hospital stay, which comes from the municipality data that is sent back to the original hospital systems. We'd have ICD-10 codes when they were available. And so the things we would not have in the data set is radiology data. I think that's very much something for the future, and I think also something that would be interesting for the discussion. And we don't have microbiology data yet, because that is usually recorded in separate systems in the intensive care unit. And we do not have clinical notes. Ideally, we'd also have the clinical notes at some point, but that generates a lot of new privacy questions. So we decided, given the urgency of the project, that we would not include those at this early stage. And so set out and just contacted all of the hospitals in the Netherlands with an intensive care units. That's 81 hospitals in total that have an intensive care unit. Some hospitals have 2 locations, but we have over 44 hospitals that currently participate and have signed all the legal documentation. We have 37 hospitals that have actually managed to extract their data and send us their data. And then we have 25 hospitals for which we've pre-processed or processed all of their data to have this sort of a cleaned version of the data set that's ready for research. And I'll tell you a little more how we get to this cleaned version of the data and what's needed for that. So I think for this project, we had a couple of pillars that were important for us. So first is collaboration. We wanted this very much to be a collaborative project, so a project on behalf of all of the ICUs in the Netherlands and also the Dutch Association for Intensive Care Medicine. So we arranged that the intellectual property is from all the hospitals, the data is from all the hospitals, and everybody from the participating hospitals can access the data and can do all of their research projects with the data. Then the second point, which is really important in gathering this data, is safety and privacy. So from an early stage, we involved the legal department, privacy officers, and we signed data sharing agreements with all of these hospitals to be able to share the data between the hospitals. And lastly, data quality was very important. So we set up a data pipeline or a coding pipeline to get to this cleaned version of the data. There was a data validation steps were sort of continuously implemented throughout the process. And this was all done with a team of data engineers, data scientists, clinicians, statisticians. We had a large team of people involved. And I think although all of these steps are very much important in setting up these projects, especially also the legal and the privacy implications, I think it'd be most interesting for this session to focus a little more on the data pipeline and more sort of the content of the project. But if you have any questions about the other parts of the project, please reach out after. And so the data content, I divided up because it's a large project, and for time-wise, I divided it up in certain challenges that we saw throughout the project. And so I split it up in these challenges, which is the data extraction, which is the mapping, data validation, and the medical concepts that aren't always included in the data. So first, I'd like to start with the data extraction. So what do we exactly mean with data extraction? We already went over that there's 3 main EPDs or electronic healthcare record systems in the Netherlands, and they've all have different backends. So they have their data stored in different table structures, and these tables have different relationships between them. So to be able to extract all these data from these different tables and knowing which tables we would need, we involved IT people from the different hospitals that had knowledge about these different systems, and we wrote queries for these 3 main systems, so we could send out the queries to new hospitals and ask them to adapt those queries to their local environment, but really sort of speed up the process and facilitate the process of data extraction. And so this is what it then looked like for each of these systems. We'd have a predefined query. We get CSV files. They would be encrypted and sent to Amsterdam UMC, where they put on a safe server where they could then be accessed and processed. In this whole step, we would get to our first data validation step as well. So for each hospital, we have a validation pipeline where we check that all the tables are complete, all the columns are complete, the headers are complete. We'd have all the data that we specified in the queries. We asked the hospitals to specify their COVID-19 patients. So they were identified by positive laboratory tests, PCR tests. In the beginning, there were no expedited tests in the beginning of the crisis, so they were all PCR tested. So they would hand over this patient group to us, and then after we have checked all these data, they would get to this staging database. So what was important for the data extraction is that we know the structure, so we involved these IT experts from an early stage. Then, which is very important, was the pseudonymization step that would happen in the providing hospitals. So we involved privacy officers from our hospital, but also from the local hospitals. And we came up with a pseudonymization technique where we could then remove all the data that we would not be allowed to gather, but we would come up with a pseudonymized ID for each patient that we could then use to track patients. So if you come up with the same pseudonymized ID in each hospital, hopefully we would be able to track patients between hospitals when they're transferred, and also when we'd get a data update. So we'd get data updates whenever there were new patients admitted. So for some hospitals, I think it was around and about every couple of weeks that we get a data update. We could link data to a previous existing patient if they were still admitted at the time of the data extraction. And then lastly, we had the data transfer. We decided on a transfer format, and everything was encrypted, obviously, so it couldn't be intercepted that way. And so that was the main part for the data extraction. And then I think one of the biggest challenges of this project, and I think of any project trying to link multiple hospitals together, is the mapping process. So what does that mean? I've taken an example here, which is the PEEP, which is positive end expiratory pressure, which is a certain pressure that you can administer to your patient on the mechanical ventilator. And we saw that even for this parameter already, every hospital would have a different parameter name. And in the Netherlands, we don't have a standardized nomenclature for these parameters. So every hospital is allowed to choose a parameter name that they think is best. But you can already see that it will be quite some work to go through these parameters and determine which of these parameters is exactly PEEP and which parameter may be something else. And then the second part of this problem is that a lot of parameters are parameters that have different options. So for the numeric parameters, it's usually easy. PEEP is a numeric parameter, but a lot of parameters are categorical or have text values, such as, for example, heart rhythm. So we'd have to come up with a system as well to account for all the possibilities that these parameters would generate. Here you see an example for heart rhythm. You see that heart rhythm can obviously be a lot of different things. So here you see atrial fibrillation, but even atrial fibrillation can be specified as AF or something else. So we'd have to come up with a system to sort of unify all these different options for a certain parameter. And that is what we did for the process of mapping. So on the left, you can see the hospital parameter names, and we would try to get those to a generic name. That would then be the same across all of these hospitals. And so that's what we try to do. We created the generic names. There are international vocabularies to do this, to link all these parameters to international vocabularies, but we saw that those had a lot of parameters that we gather in the intensive care unit aren't currently in those international vocabularies. Those international vocabularies, there's updating processes, so you can request updates to these vocabularies, but that would take too long at the beginning of the crisis. So therefore, we came up with, it was based on the international systems, but we came up with our own system that we're now trying to link to these international vocabularies. And for medication, most of the hospitals provide ATC numbers, which is standardized codes for medication that we can then use to unify all the medication administered in these ICUs. I think what's interesting to note, these were some of the values that we found in our own hospital. We went through all of these parameters that we got manually to then map them to the correct generic names. What we thought was interesting, our own hospital had a parameter pigeon feathers that was fed to a patient. I'm not sure where that happened, and we had beer alcohol free. And we had somebody who put in temperature guessed. So also in going through this, we stumbled upon some interesting values in our own hospital there. And so to facilitate this process, so after the ETL pipeline, which we went over, which deals with the data extraction, we came up with a data mapping and processing pipeline. And this is what it looked like. So on the left, we started with the parameter mapping, and we'd eventually end up on the right with the machine learning suitable data set. And so there's some steps in between there. And so the first step that we just went over was that mapping that was needed. So for the parameters, we got about 70,000 parameters from all the different intensive care units that had a different name. We try to automate this for a large part, but we saw that names are so different between hospitals that it's hard to automate. We also, for the mapping process, used a lot of other data that was available, such as mean for parameters, min, max values, or anything else that we could use to correctly map these parameters. And then for the category parameters, we got about 20,000 that we then had to map to a standardized system. So that was the very first step of the processing pipeline. And so after this mapping step, which took a lot of time, we came to the data validation step. So here you see eosinophils, which is a certain cell in the blood. We immediately see that there's an outlier there, and you can easily see that it's eosinophils expressed in percentages rather than in absolute numbers. So this is an easy way to filter out incorrect units or incorrect mappings. So throughout the pipeline, the second step that we did was a distribution check. So for all the different parameters and for each hospital, we would generate this distribution checks to check if all the units were correct, and we changed the units accordingly, and we check if all the parameters were mapped correctly. And then the last step was the medical concepts. So at first, we think that a lot of medical concepts are included in the electronic health records, but we actually found that a lot of these concepts are still missing. So here you see a graph. On the x-axis is time here. On the y-axis is dose. So here you see the blue lines are FiO2 measurements. So that's the amount of oxygen that you would administer through the mechanical ventilator. The red lines, respiratory parameters that are measured by the mechanical ventilator, and the green and the black arrows are certain times. So the green ones are sedation, and the black arrows are muscle relaxants. And you can see that there's this gap in both FiO2 measurements and respiratory system parameters. So the question is very much what happened there to the patient. Was the patient extubated and then reintubated? Did they go for CT scan? We don't know. So we came up with algorithms to determine what happened at that time point to the patient. What you can see here is that the medication was administered throughout that time point. So it's very unlikely that a patient would receive muscle relaxants while not being intubated. It's virtually impossible. So through these algorithms that we developed, we sort of try to fill in these gaps of what happened at those time points to the patients. And so we incorporated all of these algorithms, and we try to also improve on the data that we got. One of the examples is, for example, blood gas measurements. Blood gas measurements can be taken from different locations in the patient. They can be arterial, they can be venous, but they can also be central venous. There's a couple of more options. And so we really wanted to make sure that all this data was in the correct format and had all this information at the correct timestamps. So this is a sort of an extra layer that we put on top of the data. And we always try to not erase the original data, but also include the original data and this extra layer that we built on top of it. So somebody could always go back and see, what happened to the original data. And so overall, we now have 25 intensive care units that passed through the extract, transform, load pipeline, and that went through this processing pipeline. That is more than 3,500 critically ill corona patients. And we have over 200 million data points from all of these patients in all of these different domains that we went over earlier that are now available in different table structures for research. What we did as well is all the data is on a server. We created several tables. Some may be familiar with Mimic, which is an international or American data set for intensive care unit patients, which has certain table structures in place. We also have Amsterdam UMCDB, which is an intensive care data set from before Corona that was released from the Amsterdam UMC Medical Center. And so we came up with a similar table structure, and we also created APIs for researchers to work with these data, and they are all on the GitLab page for the project. And so I think the interesting part is then, so what are the results? Where are we going with this? So I think at this point in time, I'd say the machine learning that is out there in the intensive care unit or the data science projects at large are mainly fall into three categories, which is descriptive, predictive, and prescriptive. So we first with descriptive projects. So we gave an overview of what is this ICU population, how long are they intubated for, how many patients got renal replacement therapy. So very much on the descriptive side. We can also do between hospital comparisons. So we've seen what are the differences in how these patients are mechanically ventilated, for example, between hospitals. Then we can get to predictive projects, which is more, can we predict admission length? Can we predict a successful extubation in these patients? So all these predictive projects that hopefully will lead to tools at the bedside or something that clinicians can really use in clinical practice. And I think what we're really trying to get to at some point is prescriptive project. So we're currently carrying out some prescriptive projects in trying to see for what patient would proning be most beneficial. Can we actually advise or generate some clinical decision support about what patients may benefit most from proning, or what medication would be most suitable for a certain patient at a certain time. Those are the more difficult projects, I would say, but we're diving into the prescriptive part. We don't have time, I think, to go over any of these projects in great depth, but I just wanted to show some of the descriptives that we can easily gather from this data. We can look at what time point do patients die throughout their hospital admission or throughout their ICU admission. So here you can see the non-survivors in red and the survivors in green, and the patients still admitted in blue. And I think what the nice thing is about this project is that we don't only have these demographic data, but you can actually at that time point see what they die from, what was the course leading up to their death. And the same goes for other descriptives. Here we look at the intubations and extubations. When are they intubated? When are they extubated? How many patients are reintubated? What are the causes for reintubations in the intensive care unit? And then hopefully, can we predict? That's one of the projects that we've just finished. Is can we predict what patients can be safely extubated? And this is the same for the proning. So on the right side, you can see how many patients are prone, so put into a proning position. And then hopefully we can also predict which patients may benefit most from a prone position, and hopefully do some causal inference and say, what are some of the changes that we see in these patients, and can we predict or can we prescribe which patients may benefit most from a prone position. So those are some of the projects that have come out of this. I think the nice thing is that it's not only our group that has worked on these projects, but there's groups from a variety of hospitals that are working on these projects. UMC Utrecht, the Erasmus. There are several hospitals that are involved in all of these projects. And I think that was it for the Corona project, but we really want to take this project to the next step, which we've called ICU Data. I think one of the most important things or lessons that I've learned from this project is that teamwork is essential. There was an entire team behind this project. We worked together with a startup called PECMed, and they assisted us a lot in all of this data processing, and obviously all of the IT experts and clinical experts from the participating hospitals. And I think to take this to the next step is trying to gather data from intensive care patients, not only from Corona patients, but from all intensive care patients. So that is one of the projects that we're currently hoping to set up in collaboration again with the Dutch Intensive Care Association and the hospitals that have also participated in COVID Predict. And I think our goal for this project would really be, can we improve critical care for ICU patients with data? I think that's one of the central questions that we're trying to answer with this project. If you want to know more about this project, we're very much in the first phase for this project and trying to set it up. But you can go to the ICUdata.nl website, and there's a little explanation on what we're doing. And it will be very much a similar setup where all the hospitals that participate get access to all of the data from all of the hospitals that participate. So I think especially for people that are doing machine learning or rather deep learning projects, they can really benefit from these projects, hopefully to get the right amount of data that they need to train their models. I think that was it for the for my presentation. I'd like to thank you for your attention, and I wonder if there's any questions or any discussion points that you'd like to raise.
Thank you, Lucas. Very interesting presentation. Very good work. Are there any questions in the audience? If so, you can raise your hand or type a question in the chat box. Leslie has raised her hand.
So
Go ahead, Leslie.
Thank you, Lucas, for your very nice presentation. It was a very nice project. So I have actually two questions based on your presentation. And the first one is, you mentioned that all the data will be shared with all hospitals that collaborated with collecting the data. So is UMCG included in that? I was wondering.
The UMCG is not yet included in this. We have approached them, but they were really busy at the beginning of the crisis. So we're really hoping. I'd be really excited if they could join for the ICU Data project. That would really be great. Yeah.
Okay. And second, you also mentioned about the API. So what can you request via the API? Because I assume you cannot request any data via the API or.
Yeah, so the API is very much it's on the server, so all data always stays on the server because of the privacy considerations. And so through this API, it's easier to extract data from those different tables. You can also put them in a Postgres and then access it through your own SQL queries. But we thought a lot of people that are going to work with this data, especially clinicians, may not be familiar with SQL or might want to use R, for example, and so that's why we set that up.
Okay. So finally, I'm actually working on quite a similar project in which we collect data throughout Europe, and we try to use AI to improve the treatment of COVID-19 patients on the ICU as well. So I was wondering if you would be willing to meet up another time and talk about this a bit more about the project.
Yes, definitely, definitely.
Benefit from each other. Okay, great. Then I will email you about that.
Yes, just shoot me a message. Sounds great.
Okay, great. Thank you.
So new collaborations are also made. I see a hand raised by Michael. Michael, go ahead.
Good afternoon. Yeah, thanks for a nice presentation indeed. I noticed that you already use a lot of information. I was wondering whether you only use the raw data or also validated data from the hospitals. And would it be also useful in addition to have the original waveform data and maybe the alarms from all the devices in the intensive care? What do you think about that?
Yeah, that's a very good point. And ideally, I'd say definitely from a data science perspective, we'd ideally have all of those data, and we'd have, I think especially the waveform data has gained a lot of attention. We have unvalidated data available for some hospitals, but it really quickly grows in terms of data, the amount of data and the storage needed when we collect also invalidated data. So therefore, we decided for some hospitals to only collect the validated data. But ideally, for the new project, we'd upgrade the storage and also include this unvalidated data so you can work with that. And potentially even waveform.
Yeah, we are actually also measuring the data indeed every minute, and it really adds up quickly. But yeah, especially alarms, for example, they could also be used, and they are, in addition, in comparison with the data, it's something you can handle still, and then you don't have to have the whole waveforms, but you would just use the conclusion from the monitors on the waveforms, for example.
Yeah, that's a very good point. Very good point. Yeah, indeed.
Yes. So we
okay,
have.
You had another question, or Michael?
Yeah. So we do have some alarm information available. So maybe we can think about how to share that at some point.
Yeah, that'd be great. I think in general we'd really like to have the UMCG involved. So I think that'd be great if they would participate in the ICU Data project.
Yes.
Yeah.
Okay, thanks.
Okay, I got a question from Joran in the chat. He says delivery of data from source systems in CSV. I saw any options to work with APIs or a federated model. So leaving the data at the source, taking only what you need on the fly. So thinking about kind of federated approach where you maybe implement federated learning and not have all the data shipped around or stored centrally, etc.
Exactly. I think that there's a lot of initiatives also looking at sort of the federated approach. We chose, especially in the beginning, because the infrastructure was not in place to do it this way. We thought it'd be easier to sort of extract the data and do that whole processing on our side with the data. But I think this would definitely be something interesting for the future to look at, definitely.
Okay, Jorrit de Vries has a hand raised.
Yes, can you hear me?
Yes, we can.
Okay, very good. So I don't know what sort of technology you're using in the background now, but I'm hearing that there's a potential for this data collection to grow pretty fast. You're running it sort of on your own hospital service. Do you have any idea of what type of data processing technology or data storage, like databases or warehouses, would be required for this to grow this?
Yeah, so we have there is a company that provides sort of the servers that are, because the servers have to meet a lot of requirements in terms of safety and so there are companies that have these servers that we currently use and we have contracts with, and I can get you if you want the specific. I don't know the specifications by heart, but we can the specifications if you want to. But I think there we need to also look. How can we expand the CPU, GPU storage for these larger data projects to really take place?
Yeah, it would be interesting.
Yeah.
Thanks.
Okay, thank you. Any other questions from the audience? If not, I want to ask about the imaging data because you said it wasn't included yet. Mm-hmm. You also didn't mention it in your new project, the After COVID project. While I know that the Dutch Society of Radiology is building a beeldbank radiologie, so where they want to collect the data, they want to use COVID as a first trial on this. So is that something you're also thinking about to include the imaging data that you use at the ICU, or what is the approach there?
Yeah, I think that's super relevant. I think also for intensive care medicine in general, radiology data is indispensable for the patients in the intensive care unit. And so the approach, I think what we're currently doing is that we are looking if we can pseudonymize the data in such a way that we can collaborate with these radiology initiatives. So we can relate those data sets instead of doing it ourselves and collecting the data ourselves again. Also, because I think there's a lot of more radiology specific knowledge available in these initiatives by the Radiology Society that is needed to adequately analyze all this image data and the imaging reports that come from it.
But now you also don't take the outcome of the imaging into your database, or do you? So if you ask for, is there an infiltration or whatever, the outcome of the radiology you do take in your database now?
No, so there's the report is not included currently because there's some new privacy things we would have to think about, and I think maybe the Radiology Society has already thought about these, and so I think we ideally want to relate these data sets that are already built instead of reinventing the wheel ourselves.
Yeah, and then the challenge, of course, will be how to connect the same patient in two different databases, which probably requires a trusted third-party pseudonymization.
Exactly. Yeah.
able to link them together again. So that might be an additional challenge there. Yeah.
Yes. Yes.
Any other questions from the audience? I don't see any new ones. I did have one other question, because in your presentation you showed that timeline where you said, well, we see something happened with the intubation. So
Yes.
what happened there? There is no data. So was there an extubation or not? You don't know what's going on there. And later on, you showed an example where you show the graphs of the relevance of the intubation and the extubation time, etc. So how do you deal with that missing data then? Because you have to then fill that gap somehow to be able to use that patient, or do you throw out that patient in that analysis?
Yeah, no, we very much keep the patient in the analysis. So what we do is we develop an algorithm to try to determine what happened. So we know, for example, if a patient received an oxygen mask, they weren't intubated anymore. So if in that time gap they received an oxygen mask, we can be pretty certain that the patient was extubated and then re-intubated. If there's no such information, then we can look, was there a CT scan ordered, for example, at that time point? It was, so we can use all of these checks to try to fill up these gaps with some uncertainty, but we can try to filter out, some of the things some of those gaps that we are pretty confident are extubations or not non-extubations.
Yeah, so in that you try to intubate your data as good as possible and get new information in there based on the other information that you have in your large database. Yeah.
Exactly.
Trying to fill the gaps.
Yes.
Jorrit has another question, I see.
Yeah, I was actually wondering, you mentioned that, of course, besides machine learning, which usually gets a lot of attention, there's also the potential to do normal sort of business intelligence or descriptive analysis as well. My question would be, I don't know what your experience is like in this past year, but how much value do you think would be offered by not necessarily even the clinical data, but sort of in organizational data towards healthcare personnel in a crisis like this?
Yeah, I think that's a very good question. I think ideally, because now we gather data, but the data gathering wasn't real time. So if it were real time, if you could get an update, for example, every day or every 2 days, I think you could really use it also to see how many beds are available, how sick are patients in some hospitals, how much there's certain studies that look at nurse activity scores. Can you see what the differences are between hospitals in trying to determine transfers? So I think there's definitely options for that, but there's also drawbacks still that sort of prevent this real-time sort of dashboard or whatever you will implementations.
Okay. Are you aware of any efforts to sort of make what do you call that? Like a gap analysis of what the ideal situation would be and what the gap to that still is?
Yes, I think definitely the goal for the COVID Predict data set was very much sort of the clinical goal of trying to get more research going on the course of the disease and a treatment. But I think for this ICU data, we're reassessing the goals that they should have also on a larger scale. What should this data be used for, and also what can they be collected for? Because collecting data from these patients, they need to serve a certain purpose, and you need to define that purpose early on. And it's difficult to later change the purpose because that was not the reason the data was collected. So now, before we start this project, we really want to sort of define what the data can and will be used for.
Okay, thanks.
Okay, thank you, Jorrit. Are there any other questions people want to ask? Now is your chance. Nothing in the chat anymore, no hands raised. So I think everybody got the answers that they needed. Looks like there are some possibilities to start exploring other collaborations. So that's also an interesting byproduct of you being able to share your experience here and to let us know what you have been working on, which is a very interesting field, of course, and a very with a lot of data, but also a very diverse database. Thanks again, Lucas. It was very interesting. Thank you for joining us.
Thanks for having me.
Also, thanks to Femke for organizing and typing in the polls. They got a little bit delayed because in Collaborate you have to do that by hand at the moment the question is asked. So she was typing feverishly to get it in as quickly as possible, but I think it worked out fine and we could get some idea of who was there. I get at least a comment now. Great presentation, Lucas, in the chat. I think there were some closing slides that we should get on the screen. Yes, the next events of DASH are from June 25 to 27. There's a AI Hack COVID, Wake Up Your Inner Hacker. That's organized by the student organization AIMED. They are organizing this hackathon with some groups to compete on a COVID database to see what kind of information they can get from that. June 29, there is the DAME Symposium. The DAME is a project on AI in medical imaging, and it's a symposium on that project, giving you an update on what we did within that project, which was a collaboration in the Interreg between Germany and the Netherlands. And July 5 till 10, we have the Summer School Data Science and AI in Health for the first time this year. So that's also coming up very soon already. If you want to know more, visit our website. There's more information about these events and also the links how to get to more information. If you want to get in touch, you can contact Dash through LinkedIn. You can also contact Lucas, of course, via his LinkedIn profile. So if people want to get in touch with him, here is the LinkedIn link. You can also search for him, then you will find him probably. You can email us at dash@umcg.nl. If you have a question for Lucas, we can pass it on to him, or go to our website for more information. Thank you all for being here, and see you next time at the next event. Have a nice evening.